Hi, welcome to 8th edition of NH Dialogues. 8th of May is observed as the World Thalassemia Day. And I am very keen for you to know more about thalassemia. You'll be surprised to know that India is the capital for thalassemia disease of the world. Over 10,000 children in our country are born every year with thalassemia major, which is a serious problem. To answer all your questions, I have my friends here, Dr. Sunil Bhatt, who is the head of pediatric hemato-oncology of Mazumdar Shah Cancer Center at Narayana Health City in Bangalore. He is a very accomplished pediatric hemato-oncologist. He is also editor of Journal of Medical Pediatric Oncology. He is the executive board member of the oncology division of Pediatric Association of India and many other positions he is holding. On my right is Dr. Rajiv Dey. He is the head of hematology and hemato-oncology at Narayana Super Specialty Hospital in Calcutta in Howrah. Dr. Dey is also the Associate Professor of Department of Hematology at NRS Medical College, Calcutta, which is one of the best medical colleges of our country. Dr. Dey, welcome to the show, and
Thank you.
Sunil, welcome to the show. We have a lot of questions. Obviously, I can't ask you all the questions because of the time limitations. I'm going to ask you some of the common questions which are asked by many people. The first question is to Dr. Sunil Bhatt. Sunil, a lady called Farzana from Dhaka, Uttara Dhaka, Bangladesh, she wants to know, what is thalassemia? What are the types of thalassemia? How common it is? She wants to know more about it.
Thalassemia is a genetic disease, and we know we have got red cells in our blood, and the red cells carry hemoglobin in them, and this hemoglobin is the lifeline of our body. So what happens in thalassemia is that there's a defective manufacturing of this hemoglobin. So these babies are born with a genetic defect. Because of this genetic defect, the hemoglobin production is a little less, and also the red cells which are made do not live long enough. So because of that, these children, they are dependent on blood transfusion from outside. So we need to give them blood transfusion every few weeks because their body cannot make enough blood to keep them living. And if we do not give blood transfusions to these kids, more than 90% of them will die before 2 years of age. So to keep them alive, to sustain their life, we need to give them blood transfusions every few weeks to maintain their hemoglobin levels. Now, what are the types? It's usually of two types. It's called alpha-thalassemia and beta-thalassemia. It depends on which type of hemoglobin chain defect is there. And we usually come across in India, also in the eastern part of India, including Bangladesh, the more common variant is beta-thalassemia. Although yes, in Southeast Asia and some parts of China, alpha-thalassemia is also very prevalent. But for all practical purposes, the management as well as the presentation and how these children are to be managed are almost same.
Thank you. Thank you, Sunil. Rajiv, yes, Priyamvada from Bangalore wants to know, what are the signs and symptoms of thalassemia to detect it early, and what are there any tests to diagnose thalassemia?
Yes, sir. As Dr. Sunil mentioned, that thalassemia is mainly of two types depending on the genetic abnormalities, alpha and beta. But depending on the clinical manifestations, we divide it into thalassemia major and thalassemia intermedia. Thalassemia major are those patients who are dependent on regular blood transfusion for their survival. These patients usually manifest in the earlier life at around 6 months of their age, when our fetal hemoglobin are gradually replaced by the adult hemoglobin, and these patients doesn't have their normal amount of adult hemoglobin. So they manifest as pallor, anemia, and recurrent infections. And when they are transfusion dependent, they get regular transfusion. Then because of the regular transfusion, they develop iron overload. Because we know that 1 unit of blood contains around 200 milligram of iron, and daily we absorb around 1 milligram of iron. So with 1 unit of blood transfusion, we acquire around 6 months iron storage. So those patients who are on regular blood transfusion, they acquire a tremendous amount of iron. Those irons are accumulated in liver, causing hepatic dysfunction, hepatic failure. They are accumulated in the heart, causing cardiomyopathy and heart failure. They also are accumulated in the different endocrine glands, endocrine organs, causing growth retardation, gradually hypothyroidism, hypoparathyroidism, diabetes, and all sorts of things. But those patients who are having thalassemia intermedia, they need intermittent blood transfusion during some infection, surgery, those kind of things. Those patients usually present as different thrombotic episodes, like leg ulcers, deep vein thrombosis, because their blood has got hypercoagulability. So over and all, the patients which we encounter in our clinic are mostly thalassemia major. They present earlier in their life and present with anemia and other manifestations of anemia.
I feel very sad for the parents who have a child with the thalassemia.
Yes.
Sunil, a gentleman called Ashish Kumar Datta, he's from Chittagong, Bangladesh. A lot of questions from Bangladesh. How to prevent thalassemia, how to cure thalassemia, and how to early diagnosis thalassemia at the time of before the birth. That's a very important question.
Yeah.
They want to know, is it possible to diagnose thalassemia before the child is born?
Yes. I think is a very relevant question, because we know that there have been countries who have eradicated thalassemia, and Italy, Greece are one of the examples of that. Yes.
They have, Italy and Greece have eradicated thalassemia.
And I tell you how.
Yes.
See, we know that it's a genetic problem, and both the parents are carriers of this disease.
Okay.
So we cannot eradicate the carrier state.
Okay.
Because carriers anyways are asymptomatic people, they don't have any problems. But what we can eradicate is the disease, the thalassemia major itself, we can eradicate. And how? We need to know that we are carriers of thalassemia. As I told earlier, the carrier state can range from 1 to 18%. That means on an average in various parts of our country, 1 in 10 person is thalassemia carrier. So if we know our thalassemia carrier state, what we can do is what's called as premarital counseling. Number one, that means before a couple decides to marry, they get their simple thalassemia test done and see whether they are carriers of this disease or not. If they are carriers of this disease, they can still go and marry and they can still plan a child. But when the mother is pregnant, at that time, around 10 to 12 weeks of pregnancy, we can do a simple test in the mother and detect whether this child who is going to be born is got thalassemia major or not. If the child has got thalassemia major, we can abort this child. If the child has got a carrier state or a normal state, we can continue with the pregnancy.
How accurate these tests?
So this, as the time has gone by, the accuracy of the tests have also increased, and the current available investigations, it's about 99% sensitivity of this test.
Excellent.
Yes, there is still a theoretical 1% risk of missing the diagnosis, but I think 99% is still quite effective.
Great.
One more thing is what we come across very commonly in our practice is, now unfortunately, a first child in the family has developed thalassemia already.
Okay.
We didn't come to know about it. Parents didn't know about their carrier state, and the child has been born with thalassemia major already. Now, there are two scenarios here. One is that the families are so terrified to go for another child and they never think about it. So what I want to convey is that you can still plan another baby, and another baby has got 25% chances of having thalassemia, but 75% chances of not having thalassemia major. And that again can be tested by the simple test at 10 to 12 weeks of pregnancy. The other scenario is that one child has got thalassemia, and the families still plan another child, do not go for this antenatal testing and have another child with thalassemia major. So which is a very devastating situation.
Yes,
so
yes.
I think the message here is that know your carrier state and get tested at 10 to 12 weeks of pregnancy.
Excellent. Sunil, Anand Thakka from Hyderabad wants to know, is it mandatory for a couple to check for thalassemia before they get married?
My viewpoint on that is very simple, and I feel that while we do our horoscope matching, I think as a part of that we should also add the simple blood test called HB electrophoresis and to know your carrier state.
How much that costs, that test?
See, the cost of the HB electrophoresis has really come down, and it will vary from 1 to 2,000-3,000 rupees depending on which place you are doing it.
Okay.
But it's not terribly expensive.
Okay.
I know during our pregnancies, some 30 ultrasounds are ordered,
Yes,
right?
yes.
So I think there's always a place to have this one little HB electrophoresis test done, especially in areas wherein the prevalence is very high. Like we discussed in some communities, some parts of Gujarat, Rajasthan, Punjab, Haryana, Northeast, or West Bengal, Odisha, Jharkhand, Bihar, parts of North Karnataka. These are the high endemic areas. So I think it should be part of a routine investigation to be done.
Thanks Sunil. Rajiv, Arifa Begum from Dhaka, Bangladesh wants to know, I was told my daughter, three-year-old, he has thalassemia trait, but she was not given any treatment. What is the treatment? What are the associated risks, and what should I do about her?
Yeah. So, during discussion of thalassemia, as Dr. Sunil Bhatt mentioned, we need to know what is thalassemia disease, thalassemia patient, and thalassemia trait or carrier. Thalassemia, if a patient is having thalassemia, then the patient must have acquired 2 mutations from both of his or her parents. If the person has only 1 mutation in one gene and other gene is normal, we call it a thalassemia trait. Thalassemia trait are completely asymptomatic.
Okay.
Because the normal gene is hyperactive and it produces enough hemoglobin to make that person completely asymptomatic and non-anemic. His or her hemoglobin, that is thalassemia trait's hemoglobin, is either normal or in the lower range of normal. If a thalassemia trait develop anemia, there must be some other reason for anemia, not thalassemia trait condition is responsible for that. And most common cause of anemia in thalassemia trait is simply iron deficiency anemia. And often what mistake is being done by physicians, once it is diagnosed as thalassemia trait, they stop iron. They ask specifically, don't take iron rich food because it is contraindicated in thalassemia patient.
Yes.
So they becomes iron deficient.
Yes.
And many important persons are living their life normally with thalassemia trait condition. The biggest celebrity of India, Amitabh Bachchan, is thalassemia trait.
Okay.
So thalassemia trait didn't prevent him from becoming Big B. And I myself is thalassemia trait, living a normal life. So get the test done as Dr. Sunil Bhatt mentioned. Know whether your child is thalassemia trait or not. If it is thalassemia trait, he or she doesn't need any treatment. But be aware of during his marriage. So preferably don't allow her to marry another thalassemia trait so that their child can have thalassemia major. But if the thalassemia trait patient develop anemia, then evaluate the cause of anemia and treat the cause of anemia, not the thalassemia trait condition.
Rajiv, I'm sure your wife is not thalassemia
No,
trait.
she is not thalassemia trait.
Good premarital counseling has happened here.
But my daughter is.
Okay, she has trait,
Yeah,
is it?
yeah.
Okay. The Sunil, Tawheed Nisha from Dhaka wants to know what are the options for parents with thalassemia trait for a what are the options for parents with thalassemia trait for trying to have a baby?
I think we partly addressed this question, and that was that yes, if there's an option of a thalassemic trait, not marrying a thalassemic trait, that should be the first step towards prevention. But if the two parents are already trait, I mean a couple is already trait, both of them are thalassemic traits, we can still plan a baby and do that simple test at 10 to 12 weeks of pregnancy to know that the baby the mother is carrying is not having thalassemia major. And if she's having thalassemia major, we go for abortion. If the baby is normal or is even trait, we continue with the pregnancy. So it's not that two thalassemic traits who have married, they cannot have children. They can still have children, they can have normal children.
Excellent, good news. Rajiv, Rashmi from Bombay wants to know what complications can happen in thalassemia and how to follow to look for these complications.
Yeah. We know that in thalassemia what happens, the blood cells are destroyed and most of the destruction occurs in the bone marrow. So the most common symptom or complication is anemia. To treat anemia, what we do is we transfuse. And with transfusion, as I mentioned before, there is iron overload.
The blood transfusion.
Blood transfusion.
Yes.
And that iron overload causes cardiomyopathy, causes hepatic dysfunction, and in rare cases, it may cause hepatic carcinoma also, hepatoma.
Okay.
The iron overload in the endocrine organ can cause endocrinopathies, and there are complications of treatment also. The complications of treatment is because of blood transfusion, the thalassemia patients may acquire those blood transmitted diseases like HBS, AG, HIV infection, HCV infection. And as I told before, that in thalassemia intermediate patient may present with thrombotic episodes like leg ulcers, like deep vein thrombosis. So usually these are the complications. Now how to manage it? We have to give transfusion to thalassemia major patient, but we have to take out the iron which is already stored in the body, because the most common cause of death in thalassemia major is cardiac failure due to iron overload.
Okay.
So there is a chelating agent, a lot of chelating agents were there, injectable as well as oral chelatable agent. But the injectable ones are usually not used nowadays because usually it has to give 8 to 12 hours per day subcutaneous injection, which is very painful. So now there is an oral chelator, so we can give once a day that chelator, and that can take out the iron. Only one thing is it is a bit costly and it has to be taken almost lifelong. So these two are the treatment, and if there is endocrinopathy, we have to supplement the hormone, necessary hormone.
Okay. So, thanks Rajiv. The Sunil, KAM Tajul Hassan and Mohammad Sadat from Chittagong, Bangladesh, they want to know what are the medicines for thalassemia patient? Is there any procedure? How effectively a thalassemic patient can be managed?
I think we partly addressed this question in bits and pieces, but what I want to say is two things. That is, we already discussed that this child of thalassemia major needs blood transfusion. Now there are some things we need to remember when we're giving blood transfusion. One is that there is a deficiency of red cells. Other blood components are fine. So we need to give only red cell transfusion to these patients, what's called as packed cell transfusion. We should not do blanket whole blood transfusions because that has its own problems associated. That is number one. Number two is that we need to keep the hemoglobin levels or the blood level in these patients as much as normal as possible, because these children have to grow, they have to grow, and the low levels of hemoglobin, if we maintain, it will have effect on the body. The body is always under tremendous amount of pressure. Their liver becomes big, their spleen becomes big. So the message is that we need to keep their hemoglobins as much near as possible, and by that I mean when they go for blood transfusion on that particular day, try to keep it between 9 to 10, right? Because when we do that, we are keeping that in a normalish range. If we keep the levels in a lower range like 6, 7, 8, with time the liver becomes big, the spleen becomes big, there's a lot of changes in the bones which happen, and overall eventually they need more blood transfusion because the spleen eats away the blood eventually. So that's another message we need to convey. The third message is that with these red cells we do not want to give white cells, because the white cells mediate allergic reactions, and also these patients develop what's called as sensitization. That means they have been exposed to so much blood from so many different people. So if possible, we need to take these white cells out from the blood, and that can be done by what's called as leukocyte filter or white cell filter. So please try to use that white cell filter, or ask your blood bank to do that white cell filtration at the blood bank level. So that is number 3 with blood transfusion. Number 4, which is very important as well, is which partly discusses that blood can be a medium for infections, especially blood-borne infections like hepatitis A, hepatitis B, hepatitis C, or HIV, and many more. So we need to ensure that the blood which is being given to these patients is tested for these infections, because they are getting it frequently. The risk of getting this infection is very high. So we need to get this blood tested for these infections. So that is with regards to blood transfusion what we need to do. The other aspect is, as we already discussed, is that we pay a cost, we pay a price for this blood transfusion. Every blood transfusion comes with an iron overload, and unfortunately our bodies do not have the capacity by itself to take this iron out from the body. So this iron needs to go out of the body, and we need to keep them iron reducing medicines or iron chelating medicines, which we call, and they need to be given lifelong and to be adjusted as per their iron levels in the body. And number 3, which is very important as well, is we need to monitor these children. We need to monitor these children for growth, we need to monitor these children for the side effects of iron overload, and we need to monitor these children for sexual growth when they are 12, 13, 14 years of age, and that time is very crucial to keep a watch on their hormonal levels, endocrine levels. So these are some of the things which we need to do to effectively manage these children.
Thanks, Sunil. Another question to Sunil. For the last 1 year, I'm suffering from thalassemia. Is there a cure for thalassemia? How can I get rid of it completely?
I think what we just discussed was how we manage a thalassemic, and this management which we discussed, like blood transfusion and iron reducing medications, is what is a supportive care, how do we support them. The only cure which is possible, and I'm using the term today because we don't know what's going to happen in the next few years' time, the only cure which is available for thalassemic today is bone marrow transplantation. And what happens in bone marrow transplantation?
It's very interesting. I always thought bone marrow transplant is for patients with cancer and yeah.
No, I think that's again it's probably a myth, I should say, because bone marrow transplant is effective treatment for lots of conditions. Yes, of course, cancers as well, but lots of other conditions which are genetic in origin and have a problem in the bone marrow.
Okay.
So bone marrow is our factory where all this blood is formed, and we have a defect in that factory. Because of the genetic problem in thalassemia, there's a defect in the marrow. Mm-hmm. So if we can replace that marrow, change that marrow and replace it by a healthy marrow, we can cure the problem. And not only thalassemia, lots of other diseases like sickle cell anemia, which is similar to thalassemia, lot of immunodeficiency disorders, or bone marrow failure syndromes wherein the bone marrow does not work well, or we call it aplastic anemia, or other conditions wherein you can use bone marrow transplant for cure. And thalassemia, for for information of the people, forms about 25% of transplant workload in our country, because as I said, we're the thalassemic capital.
Okay.
So quarter transplants in our country are happening for thalassemia major.
Sunil, what is the success rate of bone marrow transplant for thalassemia?
I will take a minute to explain a little more, because I don't want to give a figure, and I just want to basically make people understand what is important when we talk about bone marrow transplant. There are two aspects. One is that this child who needs a transplant for whatever condition, and here we are talking about thalassemia, how well he has been managed for his thalassemia, right? As we discussed, they can have heart problems, liver problems, and other problems. If they've already developed those problems, it becomes a problem for transplant as well. So the idea is that the child has to be managed well. His iron has to be well, his liver has to be well, his heart has to be well. That will not only help in transplant but otherwise as well. So very important thing is how this child is who is going to have transplant for thalassemia. Number two is also, what is the donor status? I mean, who is going to donate for this child, and what is the matching level? Most of the transplants which we do for thalassemia are from their siblings, from their brothers or sisters who are full match. So if there's an ideal situation, and the ideal situation is that this patient who is having transplant is young child, he doesn't have much problems with liver and heart, he's a young age, and we have got a brother or sister completely matching him. We have our 90 to 95% success rates in our hospital.
90 to 95% success rate for bone marrow transplant for thalassemia.
Yes.
That's great. It's excellent. As long as they have a matched
donor. They're matched donor,
okay.
And it makes a lot of difference.
Excellent. Now, very sensitive question, Sunil.
Okay.
How much it costs?
Okay, so I think I won't elaborate it too much. I just want to say, for a bone marrow transplant, the patient needs to be admitted to the hospital for about 5 to 6 weeks. Right?
1.5 months.
They have to be in
they
the
stay
hospital.
in the hospital.
Okay, so and we can imagine that it's a resource. Resources are used during that 5-6 months, which is medications, blood products, and all other things. But still, I think we have managed to do these transplants around 10-11 lakh rupees. You can imagine 5 to 6 weeks of stay, a lot of medications, and some of them are imported, a little expensive, and that is a usual average cost for a matched sibling transplant. But having said that, there's a program in place in our unit wherein we are able to even transplant for 5 to 6 lakh rupees for non-affording or a resource.
I think this is sponsored by Lakshmi. Lakshmi Machines from Coimbatore. They are sponsoring. Yes. So you are able to do the bone marrow transplant
in 4 to 5 lakh rupees.
4 to 5 lakh. That's great.
Yeah.
Thanks to Lakshmi Machines.
I know.
Excellent. Excellent. Rajiv,
Yes.
Vikas and Rajiv Acharya from Bombay want to know, are there any vitamins or supplements that I can take as a treatment for thalassemia, or surgery is the only option? What diet should be taken?
Yeah. Vitamin for thalassemia which is used for the treatment as a supportive treatment is folic acid, because folic acid is required to produce DNA, and in thalassemia, as there is restriction of RBCs, there is tremendous amount of red cell production in the bone marrow. As mentioned earlier, the bone marrow produces about 9 to 10 times of normal of its capacity in thalassemia patients. They are produced and they are destroyed.
Yes.
So there is lot of DNA productions also there. So folic acid is required for the DNA production. So folic acid supplementation should be there. If we don't give folic acid supplementation, the patient will develop folic acid deficiency related anemia in addition to thalassemia. And vitamin C supplementation is often given, but it should be given along with chelating agents to take out iron, because it helps in taking out iron. So these two vitamins can be given. Folic acid is essential and vitamin C along with chelating agents. And regarding operation, in thalassemia there is splenomegaly and often the spleen is massively enlarged. Normally 1/3 of our blood volume is stored in the spleen. So if a patient is having a huge spleen, so an enormous amount of blood along with other components, platelets and WBCs are stored in the spleen. So if there is features of hypersplenism, means there is anemia along with low WBC count and low platelet. So it is an indication of splenectomy. If the blood transfusion requirement is too high, there is a cutoff, but we need to follow up the patients. Usually the cutoff is 200 ml per kg per year. So it's a sign that spleen is engulfing a lot of blood. So this is an indication. And often these patients develop, as there is a huge splenomegaly, infarction, splenic infarction. As thalassemia itself is a hypercoagulable condition, so it causes obstruction of splenic vein and infarction of spleen. These are the indications where we need to do splenectomy. And after doing splenectomy, it has been seen that blood transfusion requirement is less.
Okay.
Yeah, those patients who are suppose taking 2 or 3 transfusion per month, after splenectomy it has been seen that it came down to 2 to 3 month, one transfusion okay. 2 to 3 monthly.
Excellent.
But usually it is not sustainable. In next 2-3 years, again the patient develops because other organs starts producing these extramedullary hematopoiesis, liver. So splenectomy is required in these conditions, but it can't cure thalassemia, okay. and the benefit is not long sustainable. So,
thanks Rajiv. Sunil, Professor Pradeep from Mymensingh, Bangladesh wants to know, is umbilical cord blood transfusion cure a thalassemic patient?
So I think I'll take the question a different way. We discussed just now that a bone marrow transplant can cure thalassemic, and bone marrow transplant is a little older term, because when the transplant activity started first time, these blood forming stem cells were taken from the bone marrow, that's from the backside of the hip bone. That was first how it was used. But in the last almost 10-15 years, what we have also known that these blood forming stem cells can also be taken from 2 other sources. One of them is umbilical cord blood, what he is mentioning here. And we can also take the stem cells from the blood, from the veins, not from the marrow, but from the vein. We collect those stem cells from the blood of the donor in a machine called apheresis machine. It's a 3-4 hour procedure and daycare procedure. The patient comes in, donates his stem cells and goes back. So yes, umbilical cord blood is also a source of blood forming stem cells and can be used for transplant purposes. But we just need to keep few things in mind when we are talking about umbilical cord blood transplant. One is that the amount of stem cells in umbilical cord blood is limited, and it may be sufficient for a child of certain weight. It may not be sufficient for a bigger child or for adult. Okay. Number one. Number two is, although with umbilical cord blood transplant we don't need a very perfect match, but that applies mainly to transplants in cancers. But when we are talking about a non-cancerous condition like thalassemia, we still need a near perfect match, because otherwise the rejection rates are a little higher. Okay. So there are some technicalities which the treating hematologist, when they go and meet him, will discuss with them. The simple answer is yes, we can use umbilical cord blood transplant as a treatment option for thalassemics, but there are some technicalities which needs to be discussed with the treating hematologist, whether in that particular child it's a good option or not.
Excellent. Sunil, Indira Vijayan from Kochi, Kerala wants to ask you a question. Her question is, I am a volunteer of Solace, an NGO working with children with long-term illness including thalassemia. We have a few patients with thalassemia. Is there a complete cure? What are the results of BMT?
I think we discussed it.
Yes.
And sorry, I didn't catch that name. What was the name?
Her name is Indira.
Miss Indira, I want to tell you that yes, bone marrow transplant is the cure for thalassemics, and we should really, all of us, the society should work towards permanent cure for thalassemics, and you're doing a great job in other chronic diseases. I would request you to join hands with us and let us see if we can change the lives of some of these children who at least have some matched donors, and we can transplant them. And we already discussed the cure rates can be as high as 90-95% if there's a matching family donor and if the patients are in a good shape.
Excellent.
So can I add something here?
Sure. Yes,
Yeah.
yes, Rajiv.
Because thalassemia is a condition where only doctor or only parents can't handle or manage the situation. The society altogether should handle this situation, and that's why the role of NGOs like this is very important here, because the NGOs can generate awareness.
Yes.
And they can go to school, colleges before marriage and to generate awareness, number one. Number two is they can aware people about blood donation. And number three is, as this lifelong treatment is very expensive, they can help to mobilize fund for this thalassemia treatment as well as bone marrow transplantation. So the role of NGOs is very important in this condition. From Narayana Super Speciality Hospital, in this 8th May on World Thalassemia Day, we have taken some initiative. We contacted the local NGOs who are working on thalassemia or Lions Club kind of thing. So we have arranged a meeting with them to generate awareness. We have planned to start a card called Thala Care Card. We will give this card to thalassemia patients so that they can avail a free medical consultation and once a month blood count with this card. And the certain interval we need some other investigations so that they can avail in a subsidized rate.
Okay.
So these initiatives we have taken to counteract thalassemia problem as a society.
Excellent. Yeah. Great service, Rajiv. Great. The Rajiv,
Yes.
Muhammad from Algeria wants to know, my daughter is 13-year-old and she has E-beta thalassemia called thalassemia intermedia. What does it mean? Is there any problem for her?
Yes, it is a very relevant and good question, especially as far as the Bengal and northeastern provinces are concerned. Yeah. E-beta thalassemia is a type of thalassemia where one gene containing thalassemia mutation, as Dr. Bhatt mentioned, and other gene contain a E mutation, which is a special type of hemoglobin. But when this E and beta matches, they behave as thalassemia. Why? Because E hemoglobin is unstable hemoglobin, and they are synthesized in a lesser quantity compared to normal hemoglobin. So eventually they produce less amount of hemoglobin, and when they combine with beta mutation, they produce E beta, which is a thalassemia. But the manifestation of E beta thalassemia is varied. It ranges from thalassemia intermedia, where the patient may not require any transfusion or seldom require transfusion, to the extent of thalassemia major, like beta thalassemia major, where they are dependent on blood transfusion for their survival. There are lots of theories who are going to behave in which ways, but practically speaking, till date there is no single answer why these E beta patients are behaving differently, because it has been seen that in a same family, the siblings having E beta thalassemia having same mutations are behaving differently. One sibling require monthly transfusion, other siblings are okay with E beta thalassemia. But the thing is, E-beta thalassemia should be followed up under a hematologist or pediatrician. Their iron status, at least regularly, 6 months to 1 yearly checked to see what is their iron level, because it has been seen that in thalassemia intermedia, with lower level of ferritin, which is a marker of iron storage, the patient develops complications of iron overload. In thalassemia major, the ferritin level must be very high to develop that complications.
Yeah.
So E-beta thalassemia may have varied expression. They may require treatment regularly, or they may require seldom blood transfusion, but they must be under some hematologist or pediatrician and should be carefully followed up for their iron status and other complications.
Thank you. Thanks, Rajiv. Sunil, this is the last question for you from Venkatesh from Calcutta. Any role for gene therapy in thalassemia?
I think a very hot question these days on thalassemia is gene therapy. It's a dream which the scientists, which the hematologists have been having for the last couple of decades now, I think. And the idea is that why don't we, it's a genetic disorder and this is one gene which has a problem. So why don't we take that gene, take the corrected gene and put it back in the patient. And that would be the simplest form of treatment. So there's a lot of work going on in this field. There are some technical problems which are coming up, and one of the problems which is coming up is the gene is little big, and incorporation, taking the gene and incorporating it into the patient's cells which are defective has become a challenge. But having said that, gene therapy has already taken a lot of strides and a lot of progress has been made in severe combined immunodeficiencies, which are again genetic problems and have similar kind of similar kind of problems. So it's been successfully tried in combined immunodeficiencies, and I don't think it may not. I have no reason to believe that it may not happen in thalassemia. So today, if you ask me, is gene therapy available as a treatment option for thalassemia? It's not, but we hope that in the next few years to come, we should see as a treatment option for thalassemics.
Thanks, Sunil. With this happy note, let's end our NH dialogue. India, once again, I would like to inform you that is the capital, global capital for thalassemia. Interestingly, countries like Greece and Italy have eradicated thalassemia. Can we aim to eradicate thalassemia from the face of this country? It is possible. Yes, for that we need support from the government, policymakers and the people and the NGOs and everyone in this country. It is possible. Let's aim to make India a thalassemia free zone. Thank you very much and looking forward to seeing you again during next NH dialogue. Thank you.
Thank you.